So welcome to the Lyfebulb Educational Seminar Series focused on inflammatory bowel disease. I'm Karin Hehenberger. I'm the CEO of Lyfebulb, and I'm really honored and privileged to have such a great panel and co-moderator with me here today. Today's topic is nutrition and the role nutrition and diet has on the management of IBD. And we're going to talk about the maintenance and as well as acute situations when there's a need of real interventional nutrition. So I'm going to start out by introducing our Professor Emeritus, Dr. Joel Bauer, who is also the Chairman of IBD Education for Lyfebulb. And Joel will take us through the program. Welcome, Dr. Bauer.
Thank you, Karin. So today we are honored to have three excellent panelists. We have Neha Shah, who's a registered dietitian who is at UCSF, and she treats many IBD patients in that university. Tina Omprakash is an IBD patient who's an IBD patient advocate who has also published many papers on nutrition and other IBD issues. Dr. Rubin has a very large and distinguished practice, which includes many IBD patients, and he's Associate Professor of Medicine, GI at Mount Sinai Hospital in New York. So I'd like to start and talk about, what would you say, Neha, is the difference, because this is a submitted question. What is the difference between diet and nutrition? Is there a difference between diet and nutrition?
Yes, there is. So looking at the differences, diet involves what we eat, what foods are in our diet, what foods are out of our diet, and so forth. Where nutrition focuses on how we eat. This is the portions, this is the number of meals. How we eat is also influenced by our culture, our lifestyle, our access to the grocery store, and any various culinary skills in the kitchen. So to really look at the two, both are needed to really implement a successful way of eating to reduce any potential gastrointestinal GI symptoms, be it a healthy weight, as well as reduce any risk of macro or micronutrient deficiencies, which involve the different various nutrients in the diet. So yes, focus on what to eat and how to eat to really bring it all together to really individualize one's way of eating.
So again, with you, is there any, for a patient who has Crohn's disease and is managing fairly well, do you have any advice for them as to what diet to eat?
Yes.
They're doing well, they're maintaining their weight, they don't have any real issues. How do you advise them in terms of what they should or should not eat?
Yes, so I will bring a focus on fiber. So I will just quickly highlight that fiber from the various studies out there could be protective, and we're still learning all the different mechanisms out there, how this is towards inflammation. And with that said, with the day-to-day care with IBD, fiber tends to be most out of the diet in a patient with IBD. So one of the goals that I really work with my patients on is really to aiming to enhance the diet with adding more fiber to each meal, with a type of fiber which makes a difference, whether it's a soluble fiber or insoluble fiber, or low fermentable fiber versus high fermentable fiber, textures of fibers and portions of fibers to really help expand the diet. Hopefully, aiming to reduce the risk of further inflammation as a part of their medication treatment, as part of the treatment of their overall medical care, while reducing the risk of any GI symptoms. And certainly the other goal is to educate and counsel along the way, because there's so much information out there on diet that it is important to clarify any misconceptions before any changes in the diet can be made.
Is lactose intolerance an issue in IBD patients?
So from my experience over the years, many patients have developed an intolerance to dairy. Whether it's related to lactose or not, the literature is not clear on that. When I notice an observation coming from the patient that I have more GI symptoms related to diarrhea or gas or bloating related to the consumption of lactose, then it's really not a question of being dairy free at that moment. There's a huge difference between being dairy free and lactose free. And the amount of lactose from one food to another can be different, where a slice of cheddar cheese can be 0.02 grams of lactose, where a cup of milk can be 11 grams of lactose. So if there is an intolerance there, then ways to address that is to have less portions of dairy, treat it like a sprinkle or a slice, and then working on low lactose dairy, lactose-free dairy to be brought into the diet.
What about the patient who has Crohn's disease and has narrowings or strictures of the small intestine? Do you modify the diet there? And
I do.
what do you tell them they can or cannot eat? Can they have a nice big salad one day?
So with my Crohn's patients that have strictures, it's really often a focus on modifying the texture of fiber. Fiber is often restricted, more insoluble fiber, which is the leaves, the stems of leafy greens, or, certainly fiber found in nuts or seeds or skins of fruits and vegetables. Those are the big concern there for potential risk of obstruction. So with the diet, fiber is still, can be in the diet, but again, looking at the different textures of fiber, like I may not recommend corn on the cob or a big salad, as you just mentioned, but maybe something like polenta or some of these vegetables and fruits blended into a smoothie or cooked well into a soup, or some modifications I would recommend in smaller portions at a time.
I just have a clarifying question. You talk about diet in IBD. Many of the patients with IBD also have IBS. And that's something that not most, but many people in America have. So how much of what this is a functional, deficiency of an IBS related versus inflammatory and the concerns of maybe post-surgery and strictures of IBD?
So with that said, a distinction between IBD and IBS. IBD involves inflammation, where IBS does not. IBS is certainly, the symptoms can be certainly more functional, or as we call it, a change in the relationship between the brain and gut axis, where inflammation, there might be visible signs of inflammation when we're looking in depth through a colonoscopy or endoscopy of the patient. So when patients say are in remission from IBD and they still have their symptoms, right, of either diarrhea or constipation or gas or bloating, then it's really looking a little depth into the diet of where the potential triggers are, and then working with, especially with fiber, again, on the different types of fibers. So for example, if a patient with IBD, where their active disease is, quite not there, and overall the IBD is well controlled, and their major symptoms are, say, gas and bloating, then I may not necessarily recommend that big bowl of chili at that moment in time to help resolve their gas or bloating, and may focus on fibers that are a little bit less gas and bloating, such as oatmeal or certain types of vegetables like zucchini and so forth, along with bringing in aspects of mindfulness and good sleep hygiene as other ways to reduce the symptoms.
Dr. Rubin, in patients with mild to moderate ulcerative colitis, do you have any recommendations as far as diet if they're doing okay? And what parameters do you use to judge that, whether they're doing okay?
I think you have to individualize. No two patients are the same. And you really got to get to know your patient, and the patient needs to get to know the doctor and the nutritionist. And you have to individualize your recommendations depending on the patient. The degree to which the patient is going to have trouble with things like lactose I can't believe you didn't mention the word gluten yet, but or have IBS, IBD varies from patient to patient. The anatomy is different in each patient. The amount of stricturing, the amount of active inflammation, what prior surgery they've had varies from patient to patient. So it's extremely difficult to give generalized. I think you would agree that
Yes.
you cannot give blanket advice because everybody is different. I think we would all agree, I hope, that IBD is not caused by diet. There are diseases that are caused and cured by diet. Unfortunately, IBD is not one of them. Diet is important depending on what kind of IBD you have. And so if an ulcerative colitis patient is doing well on whatever therapy and they're eating a regular diet, I'm not going to restrict that diet. Enjoy, have a good
Yes.
time. Hey, let's go out for dinner and forget about the questions. Because I don't think it's going to make any difference in terms of how their ulcerative colitis is going to behave in the future. If their ulcerative colitis subsequently flares, I don't think it's going to be because of something they ate or didn't eat. Would you agree?
Yes.
What about you? Tina?
100%.
Well, I wanted to get into that a little bit, Peter. So if you have a
What about
person,
Tina? Tina hasn't really been brought into the
we're gonna
conversation.
get to Tina.
Well, what can
It's
Tina
very
maybe
important.
comment on that as well? Just what
Yeah.
from a patient
But
perspective?
Peter, I want you to
Can
focus.
Tina comment on the
Sure.
question?
Yeah,
I
sure.
missed the question. I had a phone.
I will say, a lot of patients will say, oh, that food made me flare or this food made me flare. I think that there's a lot of considerations here. First of all, I don't think that's necessarily a correct statement. I do think that there are foods that could irritate the lining of the bowel based on some of the fibers that Neha was talking about, maybe some sort of lactose tolerance or gluten tolerance factors, but I really don't feel that, a food will necessarily cause a flare. I do feel like certain foods can irritate the bowel, and I have been guilty of this too. When I had very severe perianal disease and, just rectosigmoid disease, every little thing would hurt down there. So I think it's very easy for patients to confuse this. And it's very important for us to be sharing this kind of education for patients to understand that we can't just blame this on food, especially in the South Asian IBD community. I can speak for the community I'm part of. A lot of people think diet has everything to do with this disease and that it caused this disease and they did this to themselves. We need to change that. And I don't think there is enough out there on this. And I really think that we need to do more and more to educate patients to understand this is not just a diet and lifestyle disease. You haven't done this to yourself. Don't shame or guilt yourself over this, because there's a lot of families doing that. So I think it's imperative to continue to talk about this.
Yeah, I would agree. So Dr. Rubin, in ulcerative colitis, are there certain foods or food groups that patients should avoid?
I mean, the short answer is no, but everybody is different. And you ask the patient to be vigilant. You ask the patient to pretend that he or she is a detective and that there are clues out there, and that if they're flaring from time to time, one of the things that they should consider is, did they eat anything that could have done it? Because everybody is different, and you need to listen to them and involve them in the process of deciding whether something or not, and then to run that theory by the doctor and to have a discussion about whether it's feasible or not. And you can test it, you can do it again and see if it happens again.
So Tina, going
So
back to before you were,
make any
had
ironclad
surgery.
rules about
Right.
yes or no with diet, because everybody is different. And just listen to the patient and have a dialogue with the patient, which I think what a good dietitian does as well, is to have a discussion without any preconceived notions, because everybody is different. There are things that you would never even think of that can trigger an attack, whether it's IBS or IBD. And just,
So Dr. Rubin, it's actually really interesting you say that. I tend to very much agree. I think everyone is different, and it's really important to keep some sort of food diary, right? I mean, for patients to really understand what kind of food triggers what, and maybe what it's related to when it comes to activity and medication.
I mean, they may be right or they may be wrong, but it's certainly worth discussing and exploring.
Right, but
because
you can't
sometimes they're
discuss
wrong.
something you don't document.
Sometimes
right?
it's wrong. It's, you know,
Right.
it's irrelevant, but they think it's important, but it's
Right.
certainly
But if
worth
they
paying
document
attention
it,
to and
if they
respecting.
document it and keep it in a book,
Yeah, for
then
sure.
they can relate it to the symptoms, and then it becomes relevant. So you know, as a dietitian and as a physician, as a patient, you know, what kind of tools are there out there to help patients to document and to help them guide toward a diet? Because we all know that these fad diets don't work for weight loss or for management of chronic illness.
I can briefly comment on that. I think when the topic of a food diary comes up first, as a dietitian, it is important to assess whether it is appropriate for this patient to keep a food diary or not. At times, food diaries increase the risk of what we call increased focus on the diet, to the point where patients are writing down everything that they're eating, writing down every single symptoms, portions, and so forth. And that is definitely not the goal either. So with keeping a food log, short amount of time, teaching my patient how to keep a food log, you know, that's an important piece. And then let me help them interpret the details and the patterns from that. Other aspects of keeping logs is that I like to go through every single food group and learn a little bit more what is commonly eaten and what is not. And you can easily rule out what the potential triggers are there as well. If they have no dairy and they have barely any fruits and vegetables or legume, and they're still complaining of gas and bloating, then I know their diet is so low in fiber and may not necessarily contribute to that particular symptom. So I think it all depends on the patient and what would be appropriate in that particular situation.
So I'd like to go back to Tina. So when you had your colon intact, before you had the various surgery, and the diagnosis was ulcerative colitis at that time, right? And you had no pouch, you had nothing at that point. Were there foods that you could say for yourself caused you to have flares?
I looking back, what I know now, it is difficult for me to say that any particular food caused me a flare. I do see a question here from Sam about spicy foods. I will say, like I was mentioning earlier, I had a significant amount of rectal disease and proctitis and like rectosigmoid disease, and a lot of my inflammation was there. Whatever I ate really hurt in that region. And I think, and I'm going to bring up an important topic here, I think because of that, I started to feel like I needed to restrict spicy foods and restrict certain fibers, and anything that felt like it was irritating me, like tomato sauce or soda, anything that felt like it was just hurting me. And I think this is a really good question, Dr. Bauer, because for me, it was very challenging. And I think this is the problem for a lot of us patients, to discern between what is actually causing a flare and what is irritating us or giving us symptoms. And, going back to what Karin brought up earlier about IBS versus IBD, it was later determined that I also have IBS. And even though I've been in remission for some time now, a lot of the symptoms that I have now are related to IBS. So I think this is a discernment process for patients to really learn, their bodies and sort of how to live with a chronic illness and still eat fully. And I think someone like Neha, I know, works on that extensively with patients with dietary counseling. But I just want to say that this is really a challenge. And what I'm going to bring up is very important in the sense that a lot of us restrict or avoid foods that give us symptoms, but those foods may not be needed to be restricted or eliminated forever. I think that a lot of times when we start getting our disease better controlled, For instance, when I started to use enemas and suppositories, which really helped a lot of my rectal disease, I was able to reintroduce foods, but I didn't know I could. I didn't have a dietitian back then, or a dietitian who could even understand my foods. And that's a whole other topic. Sort of those sociocultural aspects, having a dietitian who's culturally competent enough to understand that I don't just eat bread and rice and potatoes and bananas and applesauce. And these were some of the challenges that I was facing. I was really avoiding, restricting a lot of my foods, and I was scared of food. And I just want to put that out there for patients and providers who could be on today, that there are ways to work around this, and that limiting your diet doesn't have to be forever.
Peter, what would you say about a patient with ulcerative colitis who tells you that on 3 occasions over 3 or 4 months, every time he drinks coffee, it worsens his symptoms, or alcohol for that matter? What would you tell him to do?
Well, I mean, we know that caffeine is a stimulant, to bowel function. When I have constipated patients, I send them to Starbucks. Caffeine is a potent stimulus, but that doesn't mean that every time you have diarrhea, you're having a flare of your colitis.
Right.
And I would agree with what Tina said, that patients are often overly restricting their own diets based on misconceptions. They're not eating any dairy. They're not eating any gluten. They're not eating anything. And they wonder why they're losing weight is because they have overly self-restricted themselves. And that's a discussion that needs to be held. Their malnutrition is sort of self-induced. I mean, not that they're anorectic or anything, but they've made themselves that way, but because of misconceptions about what causes or exacerbates their disease. So I would totally underline what Tina said, about that. And again, so many patients have IBS, IBD. I think it's an underdiagnosed combo diagnosis. And therefore, so your patient, Joel, your hypothetical or not so hypothetical patient who says every time you drink coffee, it exacerbates its colitis, I would be dubious about that. I don't doubt that he has diarrhea, but maybe it's the caffeine, not the colitis that's happening.
So how do you, that's always a question how do you tease out the patient who has definite IBD, let's say colitis, let's make it simple, has ulcerative colitis. How do you tease out whether they also have IBS or they just have straight colitis? Is there any hints that a patient has IBS and ulcerative colitis versus the one that just has ulcerative colitis?
Well, we have a lot of objective ways of studying whether colitis is active. We have endoscopies, we have blood tests, we have, with ulcerative colitis, it's bloody diarrhea. I mean, if they're not having non-bloody diarrhea and the diagnosis is ulcerative colitis, you got to wonder whether it's ulcerative colitis or whether it's something else that's happening. So we do have ways of measuring activity, very good measures, SED rates, CRPs, all sorts of ways of seeing whether a disease is active objectively. And if all of those objective measurements is normal, then you have to think about other things in the diet, IBS, or other problems that the patient has that may be additional to or unrelated to their IBD.
It could also be side effects of the drugs, right?
Well, that's another whole area, is you always have to go look at what other stuff they're taking. And people are taking all sorts of supplements, probiotics, prebiotics, postbiotics, things that they heard about on the internet or over the fence from the neighbor that they're taking. And all of these things are going through the gut, and they can have negative effects. So a very thorough drug history is always necessary, not just prescription, over the counter and over the internet drugs. An inventory of what they're taking. Sometimes they don't even know what's in it because it's written in Chinese or something, and they don't know what they're taking. But it could be not so good for them.
I want to move on with the panelists as to what you do when a patient is failing. All right, they're on medications. which were controlling their disease. Let's be simple and say it's ulcerative colitis for the most part. And then all of a sudden, they're having 8 to 10 bowel movements a day with blood. You scope them and you see that they have ulcerative colitis. You confirm it's ulcerative colitis. Is there a role for diet there? Is there a role for giving them antidiarrheal medications? What do you do, Neha and Dr. Rubin?
Okay, so I will answer first. I think it's going to be a combination between medications and diet. Certainly deferring the use of any antidiarrheals back to the medical team, or even evaluating what is going on before we even do that. If one is coming to me with symptoms such as that, and I think it's really a degree of if they have really removed a lot from their diet and their symptoms are so significant, it's really a question of having their symptoms really medically evaluated first in case there's something going on in the gastrointestinal tract, the GI tract, before I even move forward with diet. And then in that situation, we can certainly work out options to help slow down those symptoms. But again, if the symptoms are so severe to the point one is losing weight, they're every single day, different parts of the day, there are symptoms no matter what, then it really needs to bring in from a team perspective, an interdisciplinary evaluation of those symptoms as well.
So, Dr. Rubin, how do you manage that? Or, this patient was doing quite well on whatever medications they were on, and they were not taking any antidiarrheals, and then suddenly they've had diarrhea for 5 days, and you evaluate them and you find that their the lining of their colon, whether it's rectum or rectum and colon, is worse than it was when you scoped them 6 months ago. How do you manage
Well,
that?
so you always have to have what's called a differential diagnosis. And in the case that you put where you actually looked in and so the colitis was flaring up, the first thing I would ask them is, have you recently had any change in your medication? Did you recently, for example, have some antibiotics? Maybe this is C. diff or something, a different kind of colitis on top of the colitis that you already had. Have you done any traveling? Did you eat anything weird? Did other members of your family also get diarrhea? You have to ask them all of those things. It's a rather lengthy list of possibilities. And of course, if all of those things turn out to be negative, then it's the IBD. IBD has a cycle of its own, and sometimes we don't know what I describe it to my patients as a dragon. Sometimes the dragon goes to sleep, and sometimes the dragon wakes up and breathes fire. And you don't, and IBD can do that without any obvious provocation. But you always have to consider that there was something else going on. You really are putting the blinders on if you presume that every exacerbation of symptoms is due to the IBD getting worse.
Yeah. So going back to the question that you asked before we went live, can you cure IBD? Well, let's take it one at a time. Can you cure ulcerative colitis with diet? Peter first.
I don't think so. There are lots of anecdotes out there, and there's a lot of speculation about the cause and treatment of IBD by diet. But reading, sort of being orthodox and reading the medical peer-reviewed literature of double-blind studies, don't think that diet cures the disease. It can certainly be an adjunct to anything else you do, but I don't think that in and of itself, it's going to cure the IBD. There are stories. There are lots of stories out there, but my favorite, one of my favorite statements is the plural of anecdotes is not data.
Neha, do you think that diet can cure ulcerative colitis?
At this point, no, but diet absolutely and always will matter in IBD, and it can certainly be part of the treatment and management of IBD. I will still work on bringing in the various foods that can potentially help reduce the risk of inflammation, whether it can completely resolve the inflammation and eliminate the full need for medications. I have not seen that yet in my private practice, but diet 100% still matters.
Yeah. Well, I would agree with that also, but I think there is a benefit to relief of symptoms, and I do think that diet or modification of diet can relieve symptoms. I just want to spend a couple of minutes on the very ill IBD patient. Let's say someone who has short bowel from previous surgery or extensive small bowel Crohn's disease, who is really heading towards surgery. In other words, they have had a full trial of many different IBD medications, anti-TNFs, anti-integrins, and so on and so forth. They're now 40 pounds under their optimum weight. And you feel, Dr. Rubin, that they need surgery. Let's say they need a resection of the small bowel. What do you do about that patient? How do you get them to be a better candidate for surgery?
Well, I think everybody on the panel would agree that you want to optimize their nutrition before you subject them to surgery.
Right.
And
How do you
if they
do that? How do you
if
start
they
to
can't
do
if they can't do it orally, then it needs to be done intravenously. I don't have any compunction about starting TPN on a patient like that, which is total parenteral nutrition, meaning that the nutrition is going to be administered directly into the bloodstream and not using the gut as a intermediary. You're going to eliminate the middleman, and you're going to go directly sending the nutrition into the gut. I have no problem with doing that. I emphasize to the patient that it doesn't need to be forever. This is to get them optimal shape for surgery. I think there's a tremendous amount of data, and Joel, you could certainly affirm this, that the better nutritional shape the patient is in, the better the surgery is going to go. And
I agree completely. Neha, before you start giving a patient TPN, and there are serious side effects of putting a catheter in a vein, such as infections, are there any supplements that you can try that can, let's say, a 2-week trial of something that might allow that patient to have a better state of nutrition and maybe be a better candidate for surgery?
Absolutely. So when I come across a patient where there is discussion of, possibly starting parenteral nutrition, TPN, and they have not met with the dietitian just yet, it is always imperative that that patient goes through a nutritional evaluation to really learn how we can optimize the diet. The use of what we call oral nutrition supplements, it's also called enteral nutrition in the form of oral nutrition supplements, can be introduced into the diet, either in conjunction with what they're already eating right now to really provide that source of calories and protein, or, in some cases with the use of perioperative enteral nutrition, exclusive enteral nutrition or partial enteral nutrition that could be a part of the therapy as well. With that said, I always like to recommend a combination of liquid calories and food calories, because both of them can certainly be helpful to optimize the nutritional status before any parenteral nutrition TPN is being considered.
I mean, the problem is that if they go ahead to surgery, they're not going to be able to take anything by mouth for a while.
Yes.
Their gut is just not going to tolerate it. There's going to be ileus and so forth. And so if time is of the essence, if you don't have an opportunity to do it by mouth, then I certainly would agree. If surgery is imminent, then I think I would hold the surgeon off for a while. And if you're really rushed, then I think parenteral nutrition may be the best way to go. I think you'd agree.
Yes, I completely agree.
I would agree with that too. And there were many studies about complications of surgery that occurred in people who were malnourished from their disease. And clearly preoperative TPN or parenteral nutrition reduced those complications, and especially anastomotic failures, failures of healing of splices in the intestine. Well, I think we've covered the gamut from the patient who's doing pretty well, but maybe needs a little nutritional support or help or advice. And we've gone all the way to those patients who are really in trouble, and we just have to give them a boost of something, whether it's enteral nutrition or parenteral nutrition. So does anybody have anything to add before we call it a day? Tina?
Yes, thank you, Dr. Bauer. I would just say that, I think it's, of great importance for patients to take a step back, look at their diet, especially if they feel like they're restricting a lot, as I was mentioning earlier. There are a lot of fad diets out there. I saw a question about that. There's a lot of information out there. Don't just Google this and do this yourself. My recommendation as a fellow patient would be, talk to your GI, see if there's a GI focused dietitian available that you can see within their clinic or outside of their clinic. I think it's really, really important for us to not try to go at this alone. Dealing with food and the consumption of food really does affect quality of life. It really does make or break this experience with this disease. So I think it's very, very important to work with a skilled dietitian to really understand what can you eat and are there ways to modify food so you can eat it still. And by modification, I mean cut it into smaller particles or blend it or make a smoothie out of it. There are a lot of different ways to eat. And I have learned that from my dietitian and from working with dietitians like Neha here. So I just think that, I want to empower other patients to understand that you're not alone in this, that there are skilled dietitians out there who can help patients like us live a better life and expand our diets so that we can feel like we can eat again. And so thank you. And I just wanted to make sure that I share that.
I also think that this whole discussion highlights how terrific it is to have a team, a multidisciplined team behind each patient or with each patient, including a surgeon, a gastroenterologist, a nutritionist, and a patient advocate. That's the ideal dream team, if you will, for the patient. And I think that patient is receiving optimal medical care, irrespective of what happens next.
I think that's a fantastic finish to our seminar. It's the dream team, and we presented that dream team today, and I think our patients are incredibly grateful. And so thank you so much to all of you. And I know the audience really appreciated this very frank and thorough discussion in a relatively short period of time. Thank you and have a good evening.
Bye-bye.
Thank you.
Thank you.